Hello and welcome once again to Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology. So we're finishing up the meeting. Everything is shutting down at McCormick Place here in Chicago. But I'm sitting down for my final Best of the Day with Dr. Axel Grothey from the Mayo Clinic Rochester to talk about some of the interesting GI abstracts from this year's meeting. So Axel, once again to Best of the Day. I think this may be like our 15th or 20th Best of the Day that we've done together. Something like that over the years. So let's begin with colorectal cancer, and I want to ask you about the long-awaited, highly anticipated, epically changing, practice-changing results that have consumed Alan Vanuck's life for the last 10 or 20 years. CALGB 80405. So give it to us straight, all the practice-changing results from this study.
So the interesting thing is, there will not be practice changes.
Oh,
because, no, yeah, it's true, but it's good, and because so just to remind everyone what CALGB SWOG 845 was, it was a head-to-head comparison between cetuximab and bevacizumab added to chemotherapy in the U.S. environment. Most physicians chose FOLFOX as backbone. You could have chosen FOLFIRI as backbone. The trial went through several iterations over the last 10 years in terms of, they had to integrate KRAS testing, initially. There was a dual biologics arm, bevacizumab, cetuximab, which fell out. So kind of an adaptive trial design over time. And now the final results, the overall survival results of 1,140 patients. And whether you start with bevacizumab-based therapy or cetuximab-based therapy, really didn't matter that much because patients in both arms had long, unanticipated long survival, 29 and 29.9 months, PFS completely overlapping. So whatever you choose your therapy or your frontline therapy of choice right now, you can keep it. So it's not practice changing as much as informing our practice. We're doing a pretty good job, and there are some patients who were long-term survivors. More than 10% of patients had liver resection, were rendered free of disease, had excellent outcome. So it's kind of the backbone for a lot of future studies that I can see. Now the data are very interesting because, last year at ASCO we talked about FIRE3. FIRE3 was a German trial, half the size. Primary endpoint was response rate, comparing cetuximab, bevacizumab with FOLFIRI as backbone. And this trial had no difference in response, primary endpoint, no difference in PFS, but a difference in overall survival, which we could not really explain. And there are some people
favoring
cetuximab. And there are some people who saw the survival difference, which we can't ignore, and it went, and they changed their practice, changed guidelines even in Germany. But a lot of us said, we need to have a kind of a confirmatory trial with an appropriate endpoint, larger sample size. In 8405 now, and I think this is one of the clear messages compared to last year, does not validate FIRE3. There is not, we don't see the separation of curves later on. We admittedly, and this is something we might have to talk about, we only have the KRAS exon 2 data so far.
Right. We don't know about
NRAS
and the other
KRAS,
exons,
which I think is important. But it doesn't seem to be that even if we had it and eliminate another 15% of patients, that the outcome would be dramatically changed.
So Axel, with the results of 80405 and the CAIRO3, now physicians and their patients have the option of either going with a FOLFOX or a FOLFIRI backbone and either cetuximab or bevacizumab, and feeling comfortable that neither choice is a bad choice, that they're both very acceptable.
No, I completely agree. It is. I think when we start, though, with the FOLFOX regimen, which most of us in the United States actually do, and reflecting in the percentage of patients treated with FOLFOX in 8405, we need to be mindful about toxicities. And we've talked about, in kind of utilizing maintenance strategies to prolong the duration of anti-VEGF therapy, potentially in combination with the fluoropyrimidine, actually better in a combination with fluoropyrimidine. So one of the strategies that we have to implement when we use FOLFOX first line, being mindful about toxicities, neurotoxicity, is to take oxaliplatin out before patients really get hit with toxicity. Because now, especially with the long survival we're seeing, do we really want to have these patients live for the rest of their now longer life in a palliative setting with neurotoxicity which might interfere with activity of daily living? So I think the maintenance strategy trials that we saw here at ASCO, the German trial and the Cairo 3 trial, I think they're added to our understanding of how to keep tumors from progressing by, and at the same time maintaining quality of life for patients.
So the German trial was fluoropyrimidine Bev versus no maintenance at all, and the fluoropyrimidine Bev came out the winner.
Came out the winner in the progression-free survival assessment, early endpoint. There was no difference in overall survival, and I think this is one of those things we have to keep in mind when we look at the financial impact of prolonged therapies, of these biologic-containing treatments. And I think Len Sauls gave a very pointed, of course, and expected discussion about the cost implications. Although I think we should never underestimate what it means for a patient to have prolonged progression-free survival. Patients don't like their tumors to grow. Patients like to have their tumors at bay. And do I use maintenance therapy as in most of my patients? Yes. In all of my patients? No. And when I give patients a break, it's a controlled break. I still keep an eye on these patients so that I know when tumors progress and early on, and not miss the time point of opportunity to reintroduce chemotherapy.
Right. So we've learned over the years, as the directors of 80405 learned, that KRAS is important. KRAS wild type is different than KRAS mutant, and the trial had to be changed because of that. But we're still looking for other biomarkers to define specific populations within colorectal cancer so that therapy can be targeted more specifically, more personally, as they say. And I know there is a large group of physicians around the world. Josep Tabernero has been involved in this. Scott Kopetz from MD Anderson has been involved, looking at ways of subtyping colorectal cancer into a variety of different groups, and some MSI proficient, some are MMR proficient, MMR deficient, left side versus right side, BRAF mutant versus non. And so what has this group come up with? Have they been able to set up specific, consistent, reliable groupings of patients that hopefully will eventually lead to practice impact changes?
Yeah. I mean, we're talking, when we model this after breast cancer, there's not one breast cancer. We have 5 different subtypes of breast cancer, or potentially even a lot more. Now, before colon cancer or colorectal cancer, until recently, actually, until this ASCO, there were a lot of different subclassifications or molecular pathologic basis that different groups entertained, and all these different groups came together and had a consensus statement, integrated their definitions and their subclassifications, and came up with 4 now endorsed a proposition of 4 different subclassification of colorectal cancer with different frequencies. They're not the same frequency. It's not like 25%, 25%, 25%, etc. But they have certain common features: a more mesenchymal phenotype, more epithelial phenotype, BRAF mutation or no BRAF mutation, that can have implication for clinical prognosis and practice and treatment. So I think this, I like the fact that we now have a consensus that can serve as basis for future stratification, for instance.
Right.
And also if we have, for instance, for drugs that target a certain more mesenchymal phenotype of cancer cells, which are important, and these are the worst prognosis patients, they make more sense in an enriched patient population here. We're getting into the idea of enriched patient populations more and more beyond the conventional KRAS exon 2 story, and I think this is a great move forward.
Very good. Well, let's move on to non-colorectal cancer. And I think Lee Ellis probably summarized the important abstracts in the non-colorectal session extremely well when he reviewed 4 trials, all of which are involved in the angiogenic pathway. And they were just to list these. One was the Ipatinib trial. This is a VEGFR2 TKI from China, and they did a large phase 3 trial. There was a phase 2 ramucirumab trial with mFOLFOX plus RAM or mFOLFOX plus placebo. And then there was a phase 3 Rainbow trial, also in gastric, looking at, this was second line, RAM paclitaxel versus paclitaxel placebo. And then in a little bit different line, the STORM trial, which had to do with resected or ablated hepatocellular carcinoma in the adjuvant use of a VEGFR-targeted TKI, sorafenib, which is already approved for the advanced state, versus placebo. So these are all trials involving angiogenic targets. And what are the lessons to take away from all of these?
Yeah, so in gastroesophageal cancer, we know anti-angiogenesis therapy, anti-VEGF therapy, I would say, works, because we have data from ramucirumab in second-line therapy, single agent, REGARD trial, recently published, led to the approval of ramucirumab in second-line gastric cancer, single agent in the United States. Now Rainbow in combination with paclitaxel, again, a positive result with regard to overall survival. Both of these trials with kind of overall survival hazard ratios, which were really in line with what we know from other diseases like colon cancer. I mean, the Rainbow trial with a hazard ratio of 0.81 for overall survival is very similar from what we can expect in second-line therapy with, let's say, aflibercept in colon cancer, BEV beyond progression in colon cancer. So it is interesting to see that gastroesophageal cancer seemed to be somewhat responsive to anti-angiogenesis therapy. The Ipatinib trial, again, a positive trial with a kinase inhibitor in a mainly an Asian population. And then we see surprises like ramucirumab works in second-line therapy, a single agent and in combination with paclitaxel. But in Harry Young's first-line trial, randomized phase 2, with FOLFOX, which is one of those standards of care, we have no difference in progression-free survival, no difference in overall survival, no difference in... Yeah,
that was disappointing.
It was disappointing, but also, I mean, Harry, I think, did a good job in teasing out duration of therapy. There seems to be some interaction with how long were patients on treatment, shorter with the ramucirumab than with the non-ramucirumab arm.
There was some censoring due to discontinuation from non-progressive disease.
Exactly. There's a lot of more non-progressive, patients got off therapy more commonly for progressive disease in the FOLFOX than the FOLFOX ramucirumab arm. It's more adverse events, although when you look at the toxicity tables, it really didn't stand out. So it's still some unexplained feature, and Lee Ellis, who's the discussant, said, we should not move this combination forward. And I still believe, there might be some chemotherapy backbone angiogenesis inhibitor interaction, which became very interesting in this setting. So ramucirumab, 3 trials, phase 3 trials, 2 of them positive, 1 of them phase 2 trial negative. Ipatinib apparently with activity, we'll see where this drug goes, interesting. And then the STORM trial, sorafenib, works in a palliative setting.
How many adjuvant trials targeting angiogenic pathways have we seen that have been negative? CO8?
When you look at, when you have HCC and sorafenib, I'm not quite sure we're just relying on anti-angiogenesis therapy. Because you remember, the sorafenib versus sunitinib trial was a phase 3 comparison, and sorafenib really completely was better than sunitinib. Actually, and sunitinib might be even a stronger VEGF inhibitor than sorafenib. So is it really anti-angiogenic? Is it, these dirty drugs, these kinase inhibitors, they inhibit so many different pathways. I'm always kind of questioning, how does sorafenib really work in HCC? I think it had to be done, particularly in HCC, where we have single agent activity, which is different than in other cancers like FOLFOX, bevacizumab, whatever, in colon cancer. But it didn't work. it really didn't work. The curves were absolutely negative. It was a huge investment in 1,000 patients, you know, in the study.
It was a big trial.
A big trial, and it was negative, so we need to move on. And we learn our lessons. Adjuvant setting is different than palliative setting, I mean, over and over and over again.
Jumping back to colorectal cancer, I forgot to ask you about some of the data that has been going on. There's been a lot of retrospective examinations of large phase 3 trials from over the past 5 or 6 years in which patients were or were not stratified by their KRAS status, whether they were mutant or wild type. And now we've learned that that's just not enough, that we need to know, you know, whether, you know, all of the exons in KRAS have been looked at, whether all the NRAS exons have been looked at. And I think the Crystal trial was examined this year, in the Opus trial. Are we seeing the same sort of breakdown and differences in efficacy with anti-EGFR monoclonal antibodies that we did in some of the other trials where it's been examined?
So I'm glad you came back to that, because I think the practice standard of care has changed. Actually has already changed in Europe last year, and is changing right now in the United States. So what happened was, you rightfully said we recognized KRAS mutation, KRAS exon 2 mutations as a negative predictive marker for EGF receptor antibody therapy about 6 years ago, 2008. Guidelines were changed, labels were changed. And then the large trials, panitumumab, for instance, had large biospecimen collection trials, interrogated the database. What about the role, the predictive role of the other mutations, KRAS exon 3 and 4 and NRAS mutations, which add another about 15–20% of patients to the RAS mutation mix. And I think there are consistently now very convincing data coming from the PRIME panitumumab study, but also from the Crystal trial and Opus trial presented here at ASCO, which were cetuximab-based, added to FOLFIRI and FOLFOX, that if we do not test for all RAS and eliminate those patients who have any RAS mutation, then we might, these patients don't have any chance to benefit from these agents. And in some subsets, especially with oxaliplatin-based therapy, might even be harmed, shorter progression-free survival, shorter overall survival. So it's interesting to see. I mean, it's a mutation test. It's a DNA mutation test, which is actually available in commercial labs. I don't think our community oncologists in particular are not as aware of it, because the label hasn't changed yet. The guidelines are being changed. NCCN guidelines is kind of integrating it a little bit, but for practical purpose right now, I think if someone tries to use or wants to use an EGF receptor antibody in colorectal cancer, we need to have expanded RAS testing, mutation analysis, KRAS exon 2, 3, 4, NRAS exon 2, 3, 4. And these, again, tests are available, and they can save another 15–20% of patients from the financial and real toxicities of the EGF receptor.
And I think a lot of hospitals are doing KRAS exon 2 testing, and if that's wild type, then they reflexively do BRAF mutant testing and stop. Yeah, and I think that is just no longer the standard. They've got to do all RAS testing.
Absolutely. And again, when you talk about it from a financial perspective, because a lot is kind of how can we be more financially savvy, when we eliminate 15–20% of patients with a test that might be even, let's say, a $2,000 test, which it shouldn't be, then we save just one dose of 1 month of cetuximab or panitumumab is way more expensive at $10,000 to $15,000, plus administration costs, plus the toxicities patients have.
Yeah, and that can be substantial.
It's a no-brainer from any perspective.
Very good. Axel, it's been great.
It's been great.
Can
I tell you, Jim, we have gone a long way together. I really appreciate what you've done for the field. I think everyone who's sat across from you, best of ASCO GI, etc., GU, ASH, whatever, has really appreciated working with you. And I hope and I know that patient care has improved because of what you have done.
Oh, well, that's really nice to hear. I hope so. I think we've made an impact. And I think these programs, going back to the physicians in the community, have got to be helpful.
I agree.
All right.
Thank you.
Axel, thank you for many years of discussions just like this. And thanks to all of you for watching Best of the Day from ASCO and a variety of other meetings. I have very much enjoyed bringing these programs to you over the past 10 years. Thanks again.